If you have endometriosis and you are feeling super overwhelmed and confused about the root cause to endometriosis, the different assessments and the treatment options that you have, this episode is for you. I'm Dr. Jane Levesque, and this is the Natural Fertility with Dr. Jane podcast, where we uncover the real reasons behind your fertility struggles. And in today's podcast episode, I want to break down endometriosis and all the different theories on what the root cause is, the assessments that you need to do from the conventional side, but also from the functional medicine side, if you really want to understand what's driving the endometriosis. And I'm going to go through the different treatment options that you have and that you should be thinking about if you really want to get rid of endometriosis or reverse it or heal it or have healthy babies, whatever it is. Endometriosis is on the rise. It is a hot topic. About 10% of women are diagnosed with it, but because it takes about 10 years to get a diagnosis, my assumption and what I have been seeing in clinical practice and that we all have been seeing as practitioners is that that number is probably much higher. So let's talk about endometriosis. I'm going to share my screen today and we're going to dive right in. One thing that we do in the Maximize Fertility program when you come and work with us is once a month we run an office hours with the fertility experts and we pick a topic that's hot. So this month we were talking about endo and broke it all down because even when you're working with us, you're still going to have questions, and we love connecting with everybody, so then you don't feel like you're alone, first of all. And then second of all, we try to share the latest and the greatest and the newest information with you right off the bat because, let's face it, time is money. And time in the fertility space is really, really important because, it's literally the most critical component of this journey. So if you're working with a practitioner who doesn't treat it as such, it's actually quite a big red flag. So I'm going to just break down what we talked about, and I hope, because everybody found it super helpful. So I do think that you guys are also going to find it really helpful. So the first thing that I want to kind of go through is our approach in why we do things the way that we do. It's going to connect to the root causes and everything else. So we want to take a really deep history, understanding not just your fertility journey, but your early 20s, your puberty, your childhood, the pregnancy that the mom had with you, the health of the mom and the dad when they were pregnant with you, all of these components, and you'll see why it's important. All of these components will tell us what we're really up against and how long this disease has been in the body. We want to do a lot of testing because we don't want to guess, and we definitely don't want to just start throwing supplements because we assume there's estrogen dominance. So let's do the broco shot, let's do the calcium deglucarate. We actually need to understand what's going on for you. There is usually some kind of cleansing, and I would just say deep cleansing, detoxing, optimizing all of that. We typically, you'll see the amount of testing that we do. We find so many things that the body just needs a clean slate. We need to freshen it up. Then if you need surgery, we'll actually do some things to prep for surgery. Now, the deep cleansing helps to prep for it as well, but about 5 to 7 days out, we want to get really specific. And then there's things that we want to do to heal after surgery. And my expectation is that within 3 months and definitely 6 months, but usually within 3 to 4 months after surgery, that's when we want to see our patients get pregnant. And if they're not getting pregnant at that time, and typically this is when patients come to us, is that they've had surgery already, and now it's been 12 months, 2 years, 3 years, and they actually just need another surgery now, that actually tells me we didn't do a good enough job in the history or in the assessment, and that's why the endometriosis is back. So let's talk about the root causes and what are some theories that are out there. There's a couple different papers and a couple of different theories that are floating around, but there's the retrograde menstruation, and that is essentially when the menstrual blood is not just leaving through the vagina, but it's spewing back into the uterus, into the fallopian tubes, into the ovaries. Although it's kind of an old theory. I don't want to say it has been completely debunked. There is some truth to it and some kind of logic to it, but it also misses the components of why it grows through the GI tract or the abdominal cavity, or even we're seeing endometrial tissue in the lungs or in the brain. It's missing that component. The metaplasia theory is basically embryonic development. So when you are in your mother's womb, the peritoneum and the uterus, they form from the uterus, the vagina, the cervix, the fallopian tubes. A lot of cells are forming from the same type of cell. And basically, these cells just arrest in growth until there is some kind of a trigger. And that trigger could be hormones, aka puberty. It could be oxidative stress, and that could be an infection, that could be a heavy metal, that could be mold, but there's some kind of trigger that essentially gets these cells to take them out from arrest, so then they start to multiply and to grow. And so then it explains a little bit more about why we're finding it in the peritoneum as well. And the peritoneum is essentially the abdominal cavity. And then there's some stem cell theory, and that is essentially things just traveling through it's coming from the bone marrow, so then it's blood and lymph, and that means it can travel anywhere. And this explains more why we're seeing some endometrial tissue in the lungs, in the brain, and not just in the reproductive. So our hope as holistic providers, is all naturopaths and chiros and functional doctors, is that we stop treating endometriosis as a gynecological condition. It is clearly not, because it is not just impacting the uterus, the fallopian tubes, the cervix, the ovaries. It has literally a big immune system involvement, vascular involvement, nervous system involvement, and so we essentially need to make sure that we are classifying it correctly, because right now it's not classified as such. So let's talk about, this is why history is really important. The embryonic development, there's some kind of usually arrest, or there's a genetic code that happens and that is downloaded for that embryo as it's developing in the mother's womb. And the health of the mother and the health of the father is really important, because it's genetic and epigenetic susceptibility, and that oxidative stress, which, like I said, could be coming from multiple different things, that can cause the issues with methylation, that can cause the issues with DNA damage, which essentially sets the foundation for the baby's health. And of course, some of those things, it's one of my pet peeves is when they say, oh, the baby is healthy. And it's like, are you just saying that because the baby has 4 limbs and it's crying and it looks pink and that's it? We don't actually know the health of the baby and the health of the child until it starts to grow, and we kind of get to see the environment and the genetics and what gets turned on and what gets turned off. So I think how I want you guys to think about this, this disease goes really far back. There is a genetic component, absolutely. There is an epigenetic component, which means these genes get turned off or turned on with certain environments. And there are triggers, and whether that trigger is hormonal or that trigger is environmental, it's that oxidative stress, it's just stress in general, and it's an infection, it's heavy metal, it's poor diet, it's all these endocrine disrupting chemicals. There's something that's telling the body to do what it's doing. And what I don't like that the conventional system does is just basically says, well, the body is not very smart, it doesn't know what it's doing, it's just the way that you are, it's overreacting, we need to suppress it, or we just need to get rid of the lesion. If we get rid of the lesion, then the disease is gone. And it's like saying, if I cut the weed at the top and I don't worry about the roots, it's never coming back. And now where we are, and unfortunately this is happening because so many women have undergone surgeries because they were told this is the thing that's going to fix it. It's coming back in 18 months, in 2 years, in 3, in 4 years, and it's coming back with a vengeance that now they're actually not recommending surgery unless it's preventing you from conceiving. Now, in my world, that's happening a lot, where the endometriosis is preventing the women from conceiving, and I've talked about a couple of my different cases with endo where some needed surgery, others didn't need surgery. we don't want to go into surgery blindly without understanding everything else that we're getting into, because an inflamed system, a dysregulated system, a really toxic system is not going to be able to handle the surgery well. And it's definitely not going to address all of the other underlying factors that are preventing the pregnancy, which is why women, even though they've had the decrease in the lesions and hopefully pain and some discomfort in the bloating, they tend to have that, they don't tend to get pregnant because all the other imbalances haven't been addressed or even looked into. So let's keep going here. Basically, the systems that we see that are involved, the immune system is big. There's usually some kind of microbial imbalance, and whether that's in the gut, the vaginal microbiome, the uterine microbiome, I will say the seminal microbiome because that can impact the vaginal and the uterine microbiome, the bladder. There's usually some kind of an immune response that's triggering everything to keep going. There is hormones, and we typically see estrogen that's elevated and something called progesterone resistance. So essentially the receptors don't respond to progesterone in the same way that they should. You typically need a lot more progesterone, and you need some support to work on the progesterone receptors so the body can respond to it. We have our nervous system that gets impacted. That's really important. The cardiovascular, I wouldn't even say like cardiovascular necessarily, but vascular system, the vessels, because there is a formation of more vessels. I think the lymph, I think the digestive, there's a lot. So it's not just a gynecological condition. Now, here's where the assessment comes into play. And I'm going to kind of highlight things that it's going to tell you if it's the root cause, what's causing it, versus how it's impacting the body, okay? And I think both are important. We want to be able to support the body as it has this disease, but we also want to be working on the root cause to help prevent. So we want to do a really thorough blood analysis, again, day 2 and 3, day 19 and 23. We look at a lot of inflammatory markers, iron, liver, kidney function, CA.125 marker to assess and look at uterine inflammation, endometrium inflammation. I think stool is really important. Methylation. Methylation is a biochemical process that happens in every single cell of the body. If it's glitchy, if the genetics are glitchy and you have SNPs on those genetics and you don't know how to support it, you tend to have and struggle with more diseases, including endometriosis, but really any disease is going to impact methylation, and arguably the reason that we develop disease is because that methylation isn't working properly. We have a nutrient panel. We have the vaginal microbiome and the seminal microbiome. I do think it's really important to treat the partner. We do like a complicated UTI screen where we really want to make sure we're looking at any infections sitting in the bladder, environmental toxins. Now you're thinking about things like mold and heavy metals and, the plastics and the chemicals, all of these endocrine disrupting chemicals. We can literally see it in the body. We're using the Endo Insight Plus, which is basically a dried urine analysis for comprehensive hormones, just to see how your hormones breakdown is happening. And then these are all on the functional side. When we look at the conventional side, I think getting a proper NAPRO specialist and an assessment like an MRI and a CT scan to take a look at where that endometriosis is and how bad it is and everything that it's impacting. I think having a pap smear on a regular basis is really important. A lot of women will have issues here as well. And then something like an Emma Alice analysis where we essentially are looking at the uterine biopsy to see if there's any infections. Of course, you can do an antral follicle count and make sure that the tubes, an HSG, to make sure that the tubes are unblocked. So because endometriosis is a complicated disease, we cannot just look at one piece and say, I know what's going on. Now, what I said before here is we want to understand the reason that we want to do such a thorough assessment is we want to understand how the endo is impacting your specific body, because everybody, even though you have endo, I have never had a patient who presented exactly the same way. So we still need to treat you as an individual snowflake that you are, so we can understand how endometriosis is being expressed in your body, but then we also want to understand the root cause. So if I highlight in yellow what's going to tell me how it's impacting the body versus what's the root cause, so the blood is going to show us a lot more how it's impacting the body versus the root cause. The nutrient panel is showing us the nutrient depletions, the inflammation, and all of that. The endo insight, so looking at hormone breakdowns, is very much how is endometriosis impacting all of those hormonal imbalances. When you're looking at even something like NAPRO, you're looking at understanding how the endo is in your body, where it's going, how is it growing, where is it growing, how badly, all of that. If I'm looking at the root cause, and I'll do that in green, the stool is probably a bit of both, to be honest. And the reason I'm going to highlight it both is because typically women with endometriosis will have microbial imbalances, and they'll have things like sluggish digestion and fermentation, and we're going to see that in the stool. And you might have calprotectin levels that are elevated. You'll also probably have calcium deglucarate levels, beta-glucuronidase levels that are elevated, which we need calcium deglucarate for to help metabolize that excess estrogen and get rid of it. But if we have things like parasites, if we have things bacterial overgrowth of any kind, whether it's H. pylori or E. coli or even candida, those things need to be addressed. The same with methylation. I'm going to put it half green and half yellow, because if we're testing the methylation genetics, we can see the SNPs. And a lot of women with endometriosis have a COMT gene SNP, which essentially makes it difficult for them to break down estrogens, which means they need extra support to break down estrogen. Otherwise, that estrogen is going to accumulate. Whereas the blood work around methylation, where we can look at the different amino acids and the glutathione and the cysteine and the taurine and all of those, nutrient levels, it kind of just tells us what's missing and how the body is being impacted. When I'm looking at things like the vaginal microbiome and the seminal, the UTI screen, the environmental toxin, I'm looking for root cause. I'm looking for the high levels of oxidative stress. What is driving this immune system to be dysregulated? And, what is causing that trigger to be turned on? What is the trigger that's turning on these genetics to essentially grow the endometrial tissue, and then for the immune system not to be able to recognize that endometrial tissue outside of the uterus and not really doing its job in cleaning it up? When the immune system is confused, and endometriosis is likely going to be classified in some kind of chronic inflammatory and potentially as an autoimmune disease, because the body is supposed to clean things up and it's not. So when it's not recognizing, it's not that it's stupid, it's that it's overwhelmed. And so I want to figure out what is happening, and I cannot tell you. So the Emma Alice analysis, the uterine biopsy, this is when we can flag the endometritis. And the pap smear, when we have abnormal cells, it tells us there is an infection. So we want to look and see what it is and probably do further testing, versus something like an antral follicle count or an HSG are going to tell us how the body is being impacted by the endometriosis. So if you look at this, it's kind of half yellow, half green, if you are watching this versus listening to it. But you see why we need to test. Like if you just get a really good blood work analysis, and even if you get a Emma Alice analysis and a NAPRO, you're still missing a lot of pieces. And because, like I said, endometriosis is a really complex disease, we need to make sure that we do its justice by looking at, everything that's really underneath. And this is something that my mentor said on one of our first office hours together, like 2 years ago, where she said, I love surprises, just not in my clinic. And I'm like, I don't want to find out 2 years after working with someone that they have a vaginal infection. I don't want to find that out 2 years. I want to know that now. So some of my patients, obviously, that come to me now, it's like, we do get everything done. We get absolutely everything done, especially when it's it's a chronic and complex endometriosis or adenomyosis or even PMOS. I mean, anything chronic fertility, I want to know all of these. And all of us practitioners, in my practice, this is what we do, because we are determined not just to get to the root cause, but also help the body heal. So something like a nutrient panel, low nutrients is not the root cause. It's the toxicity that's causing the deficiency. It's the pathogen that's causing a deficiency. But if I don't give your body the nutrients that it needs, it's not going to be able to clear that pathogen or that toxin, because we need energy to be able to overcome the pathogen, to be able to clear the toxins. I have a couple of people going through chelation right now for heavy metals. And it's like, do you know how many minerals they have to take to replace everything that they're being lost? And we want to support the methylation in such a big way that their body doesn't crash, especially when we're talking about fertility space. I see a lot of clinics who will just chelate to get the metal out, but they don't really care about the energy in the body, because they're like, oh, the person can recover. But when it comes to fertility, you don't have a year or 2 years to recover. That's a really long time, especially when you've already been struggling for a long time. So we want to be really smart about what we test, because the testing is what allows us to get really precise about the treatment. So let's talk about some of the options that I believe you have and that you should be asking for, and how we practice in my clinic to make sure that we actually give you a fighting chance of having a baby when you've been diagnosed with endometriosis. So if you haven't, and here's my hope for you guys, is if you're like, I have no idea what these tests are, and I have endometriosis, and I've had some blood work done, maybe you had an AMA analysis, maybe you had an APRO, which I would be surprised in, maybe you had a stool analysis. I just want to show you how much you're still missing, and not because it's you, but because nobody's talking about this, and this is why I'm talking about it, because I just am such a proponent for the body. And if the body is doing something that it's not supposed to be doing, there's a reason for it. It's always doing its best. And if I scroll up and talk to you about our history approach, every single one of endo patients has a history of high oxidative stress, of high stress, and typically puberty is a big time that there is a stress. I also typically see a lot of infections and being sickly. I also see a mom that usually was really sick, or she had endometriosis, or she was a smoker, or something. So the history taking is really, really important. Or the dad, dad was an alcoholic, or dad didn't care, or mom and dad both have diabetes, or they were fine, but now they have osteoporosis, and now they have cardiovascular disease. So you knew that there's things that were already probably going on. So we want to take a really deep history to make sure we know what we're dealing with. And then when we know that the root cause is likely started as a genetic imprint, I think the beautiful opportunity for us as practitioners and for you as the patient is to know that if you reverse this for yourself and really learn how to calm this endometriosis down in your body, when you're pregnant, those genes are not turned on, and therefore you're no longer passing this on. Which is super cool. And this is what we talk about, building that generational health, that it's not just about getting pregnant, it's about being able to actually go through this well. So what are your treatment options? Sometimes surgery is absolutely necessary. Again, I think they're straying away from it unless you're in a lot of pain, unless it's preventing you from conceiving, because they know that turns out if I go in there and I do the surgery, especially for those who have had surgery and it wasn't done well, there's a lot of adhesions, there's a lot of inflammation that wasn't addressed, and nutrient deficiencies, poor gut function and all of that. And essentially the surgery just doesn't do anything, which is a lot. You're going through a lot, you're paying a lot, and you're not recovering well. And it's scary to go through a reproductive surgery. I've had people go through and we had to take your tube out, or your ovary is now permanently damaged. This is a big deal. So surgery might be necessary, but I think the prep for it is really important. And I think most people need about 6 months, because if you do all of these testing, you will find out a lot of crap, literally, that you'll have to work through. And we just want to make sure we give the body enough time. I think I've seen people do it in 3 months, and then some people have needed, 9 months. So I would just say the average is 6. And that's my rule of thumb, whether you're going to go for IVF or any ART, or you're going to do surgery, or you're going to do anything drastic. I'd love for you to spend, 5 to 10 grand on testing versus 20 to 30 grand on a procedure. without knowing if you actually need that procedure. So the other components that are really important in treatment is you want to make sure you reduce inflammation. So that's one thing that's been coming up a lot in practice right now is spike protein clearance. And whether you've had COVID or you had the COVID vaccination, spike protein is very active and very much impacting people's cardiovascular health in a negative way, because vasculature is such an important component of endometriosis and also immune system function, that I find this has become a staple in our practice, where we need to decrease inflammation. We need to look at the spike protein load, and we can test for it. That's not even included in that, believe it or not. There's more testing out there. We want to get rid of an infection. And what I mean by that is not everybody has like ureaplasma or chlamydia or something. Also, you'd be surprised how many people are walking around with ureaplasma and they have no idea, like they have no symptoms except that it's like their bladder symptoms, or they have anxiety, or they have infertility. So you want to address the microbial imbalances. So whether that's in the stool, whether that's in the vaginal microbiome, the bladder, the seminal microbiome, whether that's mold or, really heavy plastic load, it's not part of an infection, but it's a toxin. We just want to make sure we actually get rid of it and we know what we're dealing with. It is important that both partners are treated here, especially when it comes to the microbiome. We're sharing it all the time. Hormone balances, we need to make sure that estrogen is under control. We need to make sure that progesterone in the second half is where we need it. We also need to do lots of nervous system regulation, something that my mentor, Dr. Leah Hitchman, said in one of her lectures and the courses that I've taken with her, is that endometriosis cells are trauma cells. And I think there's a lot there. If we take a really good history, we usually find, whether it's big T or little t, we find all sorts of little traumas or big traumas in the body. Just keeps the score. The body is remembering all of these things. And our environment has become quite toxic, right? You look at all the plastics and the things that are in the air, in our food, in our water, plus all the EMFs and just how little time we spend outside. It's quite detrimental. And the question is really, is the system overreacting, or it's actually reacting appropriately to its environment? And I think that it is reacting appropriately to its environment. It's just, it's hard to change your environment overnight. So there you have it, you guys. Let me kind of do a quick summary from my notes here. The big root causes we have, it's, the retrograde menstruation, which I don't want to say it's been debunked, but there's only a few components that are true to it. The other ones are kind of like, I don't know if I believe. There's the metaplasia in the embryonic development and how the cells develop. They get arrested. There is some kind of a trigger, whether it's hormonal or oxidative stress. You have your stem cell theory, so that's coming from the bone, meaning the blood and the lymph are getting impacted, so then these cells can travel everywhere. Now, the big question is, why is it surviving? And then why does it keep progressing? It survives because the immune system is dysregulated. So this is why I come back to the infection and the toxin that causes the inflammation. And when every single patient with endo that we've had in our practice, there is some kind of microbial imbalance. It might not be an obvious infection, but there is a deep microbial imbalance. And usually in the partner as well, because we attract one another based on smell. And our smell, the smell of our body is literally based on our bugs. So we have to test the partner, and we have to make sure that we treat both partners. But when the immune system is dysregulated, it essentially cannot deal with the infection, and then the inflammation goes up, the oxidative stress is higher, and the trigger continues. So the endometrial cells continue to grow. There's hormone receptor issues, and that's the progesterone resistance component that most women with endometriosis have a hard time actually accepting and linking that progesterone to its receptors. Some will also not have as many progesterone receptors, and this is why it's so important for a woman when she's pregnant to have really nice high levels of progesterone in that first trimester. I mean, throughout the entire pregnancy, but in that first trimester when the entire nervous system is developing, progesterone is supportive of that. So when a woman has really low levels, that nervous system regulation, and that nervous system is going to be very different for someone who had a mom with high levels of progesterone versus a mom who had a mom with low levels of progesterone. This is where it's like, oh, the baby was just always anxious. Okay, this is why we go back. Why it keeps progressing is essentially the continual level of inflammation and the hormones imbalance. The estrogen really feeds the histamine, and the infections feed the histamine and the estrogen. So it's this triad that keeps going. And really, what's underneath it all is there's a genetic and an epigenetic susceptibility. It's oxidative stress that causes the trigger, and it's the genetic and epigenetic susceptibility is not just when your mom had endometriosis. It's not that your dad had endometriosis, but it's just the health of your mom and your dad, their methylation capacity, and therefore their DNA damage and the level of DNA damage, which is why I'm such a big proponent for testing DNA fragmentation for men. You do not have to struggle with infertility to get this test, and the more we kind of push for it, the more it will become available. The more damage there is within the DNA, that's the genetic component that gets downloaded into the embryo, and the epigenetic is the environment that either keeps that gene on or turns it off. So for both good and bad. It's fascinating because the health of both you and your partner now will set the tone and the foundation for the health of your future child, which is why we at my practice are so passionate about doing what we do, because we know it's not just about this act of getting pregnant and having a child. It's literally setting the tone for the next generation. And what I say I'm really passionate about is building generational health. And having my 2 children has taught me so much about how hard it is in our day and age to actually have healthy children. So and my kids are quote unquote healthy, they don't have things that are going on, and I still have to be so intentional with both of them. So I hope you guys found this helpful. If this excites you and you're like, this is exactly what I've been looking for, please take 5 minutes and fill out an application. My team will review it, and if we can help, we'll make sure to reach out and show you what it's like to work with us. Otherwise, I hope you just find this information helpful and you get off the hamster wheel and you find practitioners who are going to look at your case in depth and be really invested in helping you heal, as opposed to just doing a procedure. So thank you so much for being here, and I'll see you next week.